Good morning, friends. Greetings from Manipal Institute of Robotic Spine Surgery at Manipal Hospital, Old Airport Road, Bangalore. My name is Dr. Vidyadhara, and over the next 20 minutes, I will be discussing a topic that is reshaping the future of healthcare. We'll explore how India is not just adopting but mastering this technology and becoming a global leader in precision, accessibility, and surgical innovation. The global demand for spine care is increasing due to aging populations and lifestyle changes. Historically, complex spine surgeries involve large incisions, significant blood loss, and long recovery periods. But the game has changed. Enter the robotic-assisted surgery. It represents a paradigm shift, moving us towards less invasive, more precise, and safer procedures. Although surgery has advanced a lot, friends, with respect to only techniques and technology, what has remained the same is the surgeon like me, the indications, the principles which have never changed in the last 30 years that I have been trying to be a spine surgeon. There are only 3 indications. To all those who don't know about spine surgery, it is one of the easiest of all because there are only 3 indications for surgery: weakness of limbs, loss of control of urine and motion, or pain for more than 3 consecutive months. There are of course exceptions, but 90% of mechanical back pain, these are the 3 indications. And there are only 2 surgeries in spine, irrespective of endoscopic, microscopic, robotic, navigated, or whatever. There are only 2 surgeries. If a nerve is pressed, you decompress. If bones are unstable, you stabilize. Again, there are exceptions. We have progressed from conventional surgery to minimal invasive surgery to navigated surgery, and today we are having a robotic spine surgery which is a combination of MIS with navigated spine surgery. In the past, we used to travel from one place to the other using the physical maps. Then came GPS, and today we have live GPS which tells us how long each of the routes take and where there are roadblocks and road repairs or flyover is falling. Similar is the robotic spine surgery, wherein we scan in the theatre after the patient is on the table. We plan as and when we are in the operating room, and we execute real-time instrumentation and implantation of implants. What exactly does the robotic advantage entail? It's about millimeter level precision. The robot's guidance enhances screw placement accuracy, significantly reducing the risk of damage to the nerves and the vessels in and around the spinal cord, which were quite not so uncommon with freehand techniques. Because it's minimally invasive, the patients experience less blood loss, less pain, and smaller scars. It reduces trauma to the surrounding muscles and tissues, which is a major factor in faster recovery times and shorter hospital stays. Patients can return to their normal activities sooner, which benefits both their health and over costs and access disparity. Robotics is not a futuristic luxury, it is already an ally. Our dream of having a robot began in 2012 when I was a SRS traveling fellow along with Mr. Michael McMaster, who has the scoliosis classification in his name, from Scotland, and got to visit Isidore Lieberman at Cleveland Clinic, who invented the first ever robot for the spine in 2006. I was the witness to the first ever case of robotic assisted scoliosis correction surgery in the history of spine surgery during my visit to EC. We, after 16 years, started the robotic program, or 13 years, started the program at Manipal Hospital, the main Manipal at Old Airport Road. We were the first ones to have a complete combo of MIRSS, that is the Medtronic robot, with 3D O-arm, again from Medtronic, and radiolucent operating table. MIRSS, as we call it, Manipal Institute of Robotic Spine Surgery, is one of the fastest evolving robotic spine centers globally. It has made global headlines by completing 1,000 robotic spine surgeries in just 18 months, and we have published data confirming safety and precision. This achievement demonstrates not just the adoption but the rapid maturation and integration of this technology into surgical practices in India. Our work provides unique Indian perspective, high volume, complex pathology, cost-conscious ecosystem, which I am going to discuss with few case examples, or rather too many case examples. Our success stories include patients from across the globe, from Europe to America to UK to Middle East and Africa. It's these patient outcomes that build India's reputation as a global healthcare destination. This positions India strongly on the path of being global healthcare hub, with robotics as a differentiator. Friends, we have already published 15 peer-reviewed journal publications on robotic spine surgery so far in the last 2 years. Also have pioneered cervical pedicle screws, S2LR iliac screws, the sacroplasty and iliosacral screw placement workflows, which were not there in the world. Give you few examples: early onset scoliosis, female with Down syndrome, first consultation at 2 years during COVID, loss for follow-up, child had 20-degree curve and came back in 2024 with 47-degree curve at 6 years of age. Indication for growth rod insertion, planning of upper screws and lower screws, and you see that growth rod is inserted. These are very small pedicles and you need high precision because 1 millimeter error can cause the child to be paralyzed. And again, another 6-year-old girl with L5 hemivertebra. As you can see, one half of the vertebra is developed, the other half is not. So left alone, this will progress very fast during the growth phase. Robot helped us to plan L4 to S1 pedicle screws and additionally a trajectory for drilling the pedicle of hemivertebra as shown here. A 4.5 millimeter screw in a 3 millimeter pedicle in a 6-year-old child is possible provided you are sure shot bang in the middle. And this is because the pedicles in a child are plastic. They can expand a little. However, if you are not, you can endanger the child. In addition, robotic guide allows drill multiple trajectories to remove the hemivertebra safely. And here is the adequate restoration of coronal and sagittal balance, and the child is walking within 6 hours of surgery. A 11-year-old child with Klippel-Flale syndrome, occipital meningomyelocele and proximal thoracic kyphosis with major curve of 85 and 73 degrees. CT scan revealed multiple fused vertebrae in cervical and thoracic spines. Severe webbed neck with chin on chest deformity, making the intubation for anesthesia difficult. But we have, like I said, separate spine anesthesia team, which is again first of its kinds in the whole country and in the world. They were able to intubate. We were able to do a robotic guided T11, the scoliosis correction from T2 to L3. And you see that this child had been breathless before, so we kept her in the ICU on non-invasive ventilator for 2 days and she was mobilized and discharged 2 days after surgery. Again, that girl was from Oman. A 17-year-old girl, female, from a remote village near Tumkur, presented with severe neglected adolescent idiopathic scoliosis with type 2 respiratory failure. She had discontinued school for nearly 2 years after passing 10th standard with high scores because of breathlessness. Radiographs revealed thoracic scoliosis of 168 degrees and lumbar scoliosis of 122 degrees. Friends, this is the India that we are living in. The CT scan revealed the severity of the deformity and the rib crowding. Segmentation, even with the robotic guidance, was very challenging. Planning screws was much more difficult than a regular case. So we couldn't do all the trajectories because of the severity of the deformity and inaccessibility of the trajectory through the robotic arm, as the rib hump and was coming in the way of the trajectory. However, we achieved our goal by bypassing the apex and putting screws and few screws at the apex as well. The main goal of surgery was to have an internal splint and to improve function, and she's walking after 6 hours of surgery and she is now going back to school in 6 months' time. Another employee working at ISRO, 54-year-old male, progressive deformity of back since birth, developed type 2 respiratory failure during COVID time, Jan 2021, of 6 months duration. At rest, he was breathless. He couldn't finish one sentence in one breath. X-ray showed right thoracic kyphoscoliosis of 147 degree and 115 degrees of thoracic and lumbar curves. He underwent posterior instrumented scoliosis correction. This is pre-robotic era, T2 to ileum with fusion done under intraoperative neuromonitoring. We had to bypass the apex of the curve, fixing only top and the bottom and get as much scoliosis correction. His breathlessness settled and he joined back work in 3 months. Here the problem comes. In November, he broke both the rods in 2021, exactly after 11 months, and he got breathless again. I went in again, did the rod exchange of both rods, put one additional rod at the apex, third rod, breathlessness resolved. He came back after 3 years with all 3 rods broken. And this patient's luck, we had robotics at main Manipal Hospital since 2023 and he came in 2024 and we had an experience of over 1,000 surgeries by then. Using the robotic guidance, we could plan and execute periapical screws, and we revised the robotic-assisted instrumentation on the concave and convex sides. As you can see where the drill is going, you can see where the screws are going, so that you are damn sure of helping this person, not making him paralyzed. And you can see I am drilling because if you go vertically back, patient is prone, by the way. So you are putting the screws. Now the patient has completed 1 year since surgery, doing well, going to work again and having 4 rods across the 2 rigid curves. Hope this lasts his lifetime. 78-year-old lady, functionally disabling back pain, unable to stand for 1 minute. 70-degree lumbar scoliosis. We could do minimal invasive scoliosis correction. Good outcome. 15-year-old child with 5C lumbar curve. Robotic-assisted anterior scoliosis correction was planned. This is for the first time. Nobody has tried. We were just, you get more confident and more wanting to stretch the boundaries. The feather touch drill was used to prepare the track, and screw was placed for the first time in the literature. The technique becomes challenging at the ends of the curve due to excessive soft tissue pressure. Maybe there are scopes for some technological advances in this field, and we got a good result. The child is actually a spine surgeon's daughter. Another 18-year-old girl with left flank scarring due to previous burns and neglected Lenke 5 scoliosis with curve angle of 73 degrees, very severely rigid curve. And we did the front surgery and then thoracolumbar scoliosis. So both front and back surgeries. And this is not possible without robotic guidance. 12-year-old boy, now we are going from scoliosis is the sideward bend. Now I am talking about the backward bend. 12-year-old boy, 102 degree of kyphosis. We did the scan and plan workflow, put all the screws, and then again did a second scan after the laminectomy with unilateral rod, especially as we were planning to do the PVCR, that is posterior vertebral column resection, which was being done for the first time using the navigated burr. And you can see the correction of kyphosis from 100 degree, it has come to about 38 degrees. And child had transient weakness of legs, which recovered in 3 weeks, and he is going back to school. It's now more than 1.5 years. 28-year-old male with severe thoracolumbar kyphoscoliosis. As you can see, he was not able to lie down supine. 105 degree kyphosis, scan and plan workflow. You can see above is the before surgery, before I did the osteotomy, and the below is the after the osteotomy. And you can see I've removed 3 bones around the spinal cord and got good satisfactory balance.